with the history, first of all.
So I've told you the history. He was playing football, and this is where he's turned up, like, yeah?
So what I have to tell, is it the clinical findings that I'm appreciating or a
So look at the
diagnosis?
X-ray and describe it. Look at the picture and describe it. Yeah, see what you see. It's a knee.
Okay. Okay. This is the image of left knee showing distal thigh and proximal leg with gross deformity at knee joint. I can appreciate a posterior subluxation of tibia and prominent
So see
bump
now
on the lateral.
you're running around the place. In the exam, what you see and what you know, you tell them. So tell them this is a left knee dislocate, which looks like it's dislocated. I would like
Dislocated.
to
Okay.
see an X-ray of this picture if it's possible. Okay.
Okay. So
So in the
I have to take.
exam, you have to be very obvious. You have to give information as soon as possible.
Okay.
This is a dislocated left knee. Okay. What else do you want to know now?
Sir, should we say that it is a fracture dislocation of left knee?
No, this
looks like proximal tibia fracture.
You don't know fracture. You can just say it's a patient. Right. What you'd like to do is have an X-ray. Okay. So do you want an X-ray picture? So that's the X-ray of the patient. Go on, Javed. Continue.
Yes. It's a X-ray knee joint, AP and lateral view, showing posterior dislocation of the knee joint, anterior dislocation. Sorry, anterior dislocation of knee joint with a small avulsion fracture of patella. I guess it's not clear, but I can appreciate a separate segment from the patella.
There is a small little avulsion, but not much. Okay, so a lot of plasters and everything's going in. So what are you going to do now?
So I will, assuming that this is an isolated injury and patient is vitally stable, and after taking consent from the patient, I will maintain the IV line. I will give analgesia, and I will close reduce under sedation.
So that's what we did in A&E. Okay, so we reduced it. Okay, so what next?
Okay, so I will examine his pulses, distal pulses and neurovascular
status. Not very good and not very clear.
Okay, but then I will go for the capillary refill. And
no pulse. So you want to say, okay, fine, you do the capillary refill. You've done a capillary refill, and it's okay.
I will admit this patient for observation. Might be the vascular popliteal vessel might be in the spasm, post-traumatic.
So what do you want to do?
Yes, sir.
You reduced it, and you think that may be a vascular injury, so you can't just admit the patient. You want to do a bit more, isn't it? So what do you want to do? You want to stabilize it, and you want to see if the vessel is okay or not. So how will you?
So can we do Dopplers, ankle brachial index?
Yes.
So can we do Doppler studies and ankle brachial index?
And it's not right.
Yep.
There's a difference. It's more than one.
Okay. So I will go for Doppler ultrasound.
We've done that, and it tells you that the ankle index is more than one. So this is what you do next. What is this?
MR.
CT angio.
CT angio.
Okay.
Yes. So what's happening here? Can you see it?
Not clearly, sir.
Okay, so the popliteal artery has got an intimal tear. Okay, there's contrast going into here, but there is no contrast in the middle of it. So this is an intimal tear of the popliteal artery. So what next?
Is that a complete block?
No. It's going up here, and it can trickle down to the bottom of it, but there is an intimal tear. There's no complete block.
So he
can't getting contrast going down.
So he needs a revascularizing procedure, probably as early as possible, within 6 hours.
Okay, so what are you going to do in the meantime?
To stabilize the knee.
How will you do that? Very good.
It's by fixation external tibia. External fixator.
You have to ask all these things for the answers to come in. So in the exam, if it's a dislocated knee, the first thing you would do is to try to relocate it. Once you've relocated it, you look at the vascular index. So you do an ankle brachial index, which is higher in this person. That's what the examiner will tell you. You will then do a CT angio. The CT angio has told you that the continuity is maintained, but there's an intimal tear. So what you'd like to do now is to stabilize the knee to get a vascular surgeon's opinion to see what's happening with this patient, isn't it? So what you would do, as you rightly said, you put an external fixator on, and this is what we did. Okay, so we put an external fixator on it, and the person has been assessed by a vascular surgeon. Why are we not doing an MRI scan here to look at the collaterals in the ACL and the PCL?
Because it's too early, and the other thing is we have applied a fixator, and so in the early phase we cannot go for the MRI.
Okay, so what is the exam answer? Do you remember
exam
triage? ATLS triage, A, B, C, D. So MRI scan to assess collateral is D. So C comes before D, so we need to do the vascular problem first before we can do the knee problem, isn't it?
Okay. Can I ask a question, sir?
Yeah.
So after that traumatic dislocation of knee, when we will be going for MRI exactly? Is it immediately after you reduced it, or you have to wait for
ATLS A, B, C, D. C is vascular.
Yes, initial examination part, we have discharged the patient, or we have admitted the patient for observation. So for how much weeks we have to wait to get MRI to settle
Once
on
you have got the vascular problem out of the way, patient is stable, you can have an MRI scan. So we had the MRI scan of the patient the next day. Okay, but we wanted to do the vascular bit first. The vascular surgeon came in and he looked at it and he said that there is a tiny interval tear, it doesn't need surgical correction, so you can do what you want to do. So that's what we did. We then did an MRI scan of this patient. Okay, remember the exam. I know A, B, C, D. Everything has to be A. Airway comes first, then breathing, then C. Dislocated knee with vascular interval tear is a C. Pelvic open loop fracture is a C. You cannot talk about vestibular, fractures, or you cannot talk about assessing vestibular fractures or assessing patellar fractures or soft tissues around the knee unless you have a stable C. Okay, these are all basic principles for this. Okay, so now we have done C, we have stabilized the patient, we have done an MRI scan. Anybody want to comment on the MRI scan? We're going upside down, Javed. Is your telephone turning around, is it?
Yes, my screen is rotating, sir, sorry.
My MRI scan has made you go into circles, is it?
Okay, so it's a MRT1 weighted image, AP and coronal and sagittal view.
Yeah.
I can appreciate bone bruise at the proximal tibial level.
Yeah, so generally it doesn't show you much, isn't it? So we did this next then. So what does this show? You can see that there's an external fixator in this patient while the patient was having an MRI scan. Okay, so what is this picture showing you? So there are two things you will see.
Yes, it's a PCL avulsion.
Yeah.
Right, it's complete PCL avulsion from femoral side.
So there is PCL is here and ACL is here. They're both not working. Okay, so PCL is gone and ACL is gone. Correct.
Yes. Right.
And if you can look at this X-ray, you can see it, MRI scan. You can even see it better. The PCL is gone. So the reason I've not shown you other MRI scan is there was no posterior lateral cord injury. There was no medial collateral ligament. Nothing. Everything was all okay except these two ligaments were gone. So do you remember attending Sufyan and Kazim's lectures?
Yes.
So how are you going to manage this?
So initial we will discharge the patient on cryotherapy and analgesia, and later on we will plan for the reconstruction, keeping in view the age and profession of the patient.
I told you this was a 30-year-old, yeah? So this is a person who's playing football, so he's a young person, right? So do you know any protocol that's going to help you to manage soft tissue injuries?
Regarding the reconstruction?
Yes.
So basically the acute reconstruction in this case is much more better than the chronic reconstruction. So as you told, there's a vascular injury. Sir, as you told, there's a vascular injury. There's MRI showing a vascular injury. So it's in the same setting. If you are repairing the vascular injury, can we go and repair the ligamental injury too?
No. Because the C comes before D, okay? So what you're going to do is stabilize the knee, which we have done. Then the vascular injury is corrected. But this person did not need to have a vascular injury. So then we go back to the soft tissue problems now that we've gone from C to D, okay? This person has a ACL and PCL gone. Now, the other day, Kazim and Sufyan told you that the posterior lateral corner comes as a priority. Once you've done the posterior lateral corner, then it's the PCL that comes as a priority. Sorry? Posterior lateral corner is first, PCL is second, ACL is third, okay? So if this person is now stabilized, you can plan this patient to have an operation. Normally what I would do then is take this external fixator out and put him in a PCL brace. I won't send him home, but within this admission, within the first couple of weeks, if there was a posterior lateral corner, I'll do that, and then I'll do the PCL at the same time. Now, if this person is too big, then you could put them in a brace and review them in 6 weeks' time and reassess them again. Most of these, if there is no posterior lateral corner, can be stabilized without fixation, except that ACL still needs doing. Okay? So if you do an early ACL, what will happen?
So there's a myofibrosis at the end of the ACL.
Arthrofibrosis, you can have that. Okay? So you can have arthrofibrosis, but if it's a posterior lateral corner and a PCL, then you have to do those early. If you want to do all 3 ligaments, you have to be very talented to do all 3 at the same time. So in the exam, the answer is I will stabilize this, exclude vascular injury, and get my soft tissue knee surgeons to come and help me out in this one. Okay? But the plan is that everything, posterior lateral corner first, PCL second, and ACL third. And you can do them within the first, but you have to do them within the first 4 weeks. Anything before that, you'll have arthrofibrosis. Anything after that, it'll be very difficult to get good results on the posterior lateral corner and PCL. Be happy with that?
To wait for the 4 weeks, right?
At least 4 weeks before you do anything. You know, it needs to be done early, but you don't want to do it too early if you're going to do the ACL together. But if you want to do on its own the posterior lateral corner and PCL, then you can do it anytime you want to when you have access to the soft tissue. So this one now, who wants to go? We did it the last time this morning, but nobody had a very clear-cut view on this. So I thought I'd put it back again. Yeah. So who wants to go?
So it looks like a hyperabduction injury, luxtra recta, something like that.
No. This is not what you say in the exam, sir. In the exam, what would you say? This is a shoulder of a skeletally mature person. This is the right shoulder. On the shoulder, you can see what? What is this called? Do you know what this is called?
So I think this was a previous X-ray in which we were taught by.
I want to do it again because I want you guys to do completely well with it, isn't it?
It's,
I don't mind whoever wants to answer, but we need to do it properly, okay? So that everybody can learn. So who's doing this? Do you want to do this? I mean, anybody can volunteer. I don't mind. You just need to go on. We can't wait for people to want to volunteer, isn't it?
Sir, it's posterior dislocation of the right humerus.
Okay.
There's
more to it, isn't it? So if you were going to say this in the exam, you say the right shoulder, which is showing a light bulb sign, which means that there is a posterior dislocation. Yeah? Okay. But on the lateral view, there's a lot more information. What is the lateral view showing?
Sir, empty.
Sir, there is defect in the head of the humerus.
Yes.
Look like pancart or like that due to there is a recurrent dislocation.
No. It is not a, well, it is a dislocation, it's a posterior dislocation, but this patient is showing something more than a dislocation. This is a very common injury people see in Pakistan. This is called a locked posterior dislocation.
Yes.
It is a locked posterior dislocation. Agreed?
Yes, sir.
Yeah, that's because this patient turned up to clinic after having a fall after 6 weeks. By that time, nobody had reduced the shoulder, so this was a locked posterior dislocation. So what is the plan of management now?
Sir, we will go for a McLaughlin procedure.
Okay. So
For this, we have to transpose the subscleral
answer to the
into.
exam is I will take this patient to theater, consenting him from a
Yeah.
closed manipulation, and also
Yes.
consenting him for an open manipulation with an ultimate treatment at the same time. This patient
Yes.
has got a lug posterior dislocation. He also has a big, huge cavity from the lug posterior dislocation. So, in my view, this patient is not going to be reduced, closed, and even if I
Okay.
open it, it will be very unstable. So, how will you manage this now? Now that I've told you that it's an unstable fracture, it's an unstable dislocation, and it's a lug posterior dislocation.
Yes. For definitive treatment.
Yeah, what's the definitive? So the definitive treatment is depending on what age the person is, his
What age of the person, the activity level, and if it is below 65, if it is above 65, we will go for the shoulder replacement. If it is below 65, as we were taught in previous
answer
session.
this in the exam as previously discussed. You're now telling me what it is. What I would like you to say in the exam is that if this patient is above 65 years, then this person should have a reverse polarity shoulder replacement, okay, or a reverse shoulder replacement. If this surgeon is below, if this person is below 65, then I have a few options. Okay, so what are your options?
So one is the needs modification of McLaughlin procedure in which we transfer lesser tuberosity and associate subcutaneous tendon into a reverse, like in a reverse Ilsac lesion. We used to transfer the lesser tuberosity.
Yes, so you transfer the subscap, so you provide a sling so that not only do you reduce it, but it stops you from falling back into the cavity again, isn't it? So you do what is called a McLaughlin's procedure, okay? Where you take the tuberosity, which is the lesser tuberosity, with the subscap and put it in. What are your other options?
Other options were.
So you can put a bone graft in this, take the iliac
Bone
crest,
graft.
fit it into there, right?
Yes.
And then still do a soft tissue procedure where you take the subscap and use anchors or sutures and stitch it to it. The third option is you can take a allograft, a humeral head, okay, and you can take the defect and put it in. The fourth option is you can take a metallic button. They come in different shapes, but they are specifically made for people who have a young, but who have defects in their humeral head. So you actually put a button in there, which is like a metallic button, but you still have to do the McLaughlin's, i.e. the transfer of the subscap. Otherwise, it will keep falling up at the behind the shoulder, okay? So
Yes, sir.
in the exam, can we summarize this? If you see this X-ray, you will see that this is an X-ray of a skeletally mature person who has got a bulb sign, which means he's posterior dislocated. If they don't show you this X-ray, then ask for a lateral view in the X-ray. When you get a lateral view, the lateral view is showing that this is an old injury. This is a lug posterior dislocation. So then they will ask you what you would like to do. And you would tell them that depending on the age of the person, I will take the consent for the patient, assuming that this is an isolated injury, no contraindication to surgery. I would try to reduce this closed, which if it fails, I do it open. Once I've reduced it, I have a feeling that this is not going to stay here. So I would do a definitive procedure. I would either do a McLaughlin's or whatever is available to you, or if the person is above 65, I do a reverse polarity shoulder replacement. We happy with this?
Yes, sir.
So if this comes in the exam, you'll be able to answer this. There is a lot of neglected, dislocated posterior shoulders that will come in the patients. I know there's at least 4 or 5 pictures that I've seen that this is what is going to be. One of you will get it. So you need to have this completely, perfectly, you know,
Sir, may I ask how bulb sign is appreciated on the AP view?
How is what, sorry?
Bulb sign is
okay. If you look at a normal shoulder, the humeral head is here, okay? This is round. Yes. This is very classical. It's like a bulb, okay? This is not what a normal shoulder looks like. A normal shoulder should have a tuberosity and then the articular surface facing to the glenoid. The articular surface here is facing posteriorly. Here, you can see the articular surface there. So the tuberosity is facing you and the articular surface has gone back. This is called a bulb sign or a posterior dislocation.
Okay, sir. Okay, sir.
Happy with this?
Yes, sir. I got.
Okay, so let's go somewhere else.
Yes, sir.
I don't have any more. Why have I not got any more?
As
yeah.
Yes. Sir, can you slide back?
What, sorry?
Yeah, sir. On this slide, I want to ask on.
Yeah, go and ask a question.
Yes, sir. Not on big slide, on a shoulder slide of a shoulder, please.
So you're going to ask me something on here?
Yes, sir. Yes, sir.
Go on.
Sir, on this X-ray, is there any special distance between the tuberosity and the acromion?
Okay, so that's only when you have a standard picture. So you have to have everything very standard, all these position of the gantry and the picture taking. So you cannot just look at any X-ray and decide whether the distance.
Yes.
Okay, so you have to have very standard pictures. Once you have a standard AP picture, then 10 millimeter or more is the cuff intact. Up to 5, it is torn, and beyond 5, it is completely deficient, like I said, filament. But you have to have a very standard picture. You can't comment on every picture. So that distance is only, you have to have a very standard picture to make a comment on that picture, yeah?
Yes, okay, sir. Okay.
Let's go and see if we can show you something else.
Right, sir. Okay, sir.
Okay, so what do you understand about dislocate or an open book fracture? Can somebody take that? I'll show you this X-ray again, but go and have a look at it. What do you think? Can you see it?
Yes.
Okay, just a minute. We did this morning, but we want to make sure you know more about it. So what do you see?
Sir, open book fracture of the humerus with diathesis.
Please, guys, you're going to do the exam in a couple of weeks' time. So you need to say this is an X-ray of a skeletally mature person showing an X-ray where the obvious injury is there's an open book fracture. Okay.
Yes.
Do you know what a Polo-Mint theory is?
Yes.
What's a Polo-Mint?
If you have a skeletally mature patient showing both hip bone with the proximal femur and sternum showing open book fracture with the right SI joint disruption, probably.
This one, yeah?
Yes.
Okay. So how are you going to manage this?
Sir, after going for HLS protocol, after going to HLS protocol, I will assess the hemodynamic stability, and if patient is hemodynamic stable, I will apply pelvic binder. After that, if patient is hemodynamic stable, I go for CT angiogram.
Okay, so the CT angiogram is stable. The person you have binded it is now done. So what ultimate treatment or complete treatment will you do for this patient?
After complete treatment, I will take the consent, and I will take I will go to the OT and will apply the X-Pix. In X-Pix, I will apply the pins in the delta position in which both columns will be connected to one another.
Okay, so you will do something like that, yeah?
Yes, sir.
Okay, so what are the signs that there is a lot more going on in the pelvis? What would you be looking for, which are worrying signs?
Sir, there was scrotal.
So there is
Marvel
Lavely.
What else?
So there is Marvel Lavely syndrome, like there is extravasation, bruises over the back.
Okay.
So there is subcutaneous extravasation of the blood.
Okay, so the one is having urine coming out of the rectum. 1, 2, scrotal hematoma. 3, blood coming out of the urethra or the perineum. 4, what is a Laurel-Lavelle lesion? Do you know?
Moral level, yes.
Yes.
Sir, it was extravasation of blood in the subcutaneous tissue that gave bruise appearance.
So this is when you fall and have an accident, this blood will glove. Do you know a classification of degloving of injuries around the body? Does anybody know a classification around degloving on bones? when there is no fracture but you have degloving injury?
Sir, T-sharp is suited with the
Is what, sorry?
T-sharp is T-sharp classification is associated with
T-sharp
fracture.
classification, that's very good, yeah. So anywhere from some bruising, hematoma to total lifting off from the skin, there are 5 grades in it, okay? But that's right, it's called T-sharp classification. We don't have any, these are worrying sign of the pelvic fractures when you have blood in the urethra, bleeding PV, you have edema of the labia, and you have leaking of urine from the rectum. These are classical features of a pelvic fracture, which is causing you problem. Okay, so I wanted to show you another very nice picture somewhere if I can find it. Yeah.
Yes, sir.
Okay, I don't have it. It must be on my other presentation. You know, classification system for these, yeah?
Yes.
So what is the classification system?
Youngberg's.
Okay, so what is the Berger's classification then?
Sir, in this.
So it's an AP, anti-posterior injury, and it's 3 types in Rung and Burgess.
Okay.
Type 1 is symbiosis pubis is less than 2.5 cm. There's a dissociation less than 2.5 centimeter.
Describe them as a stable and unstable injuries, okay?
Okay.
First of all.
Yes.
And then it is on the direction of the forces that are going through it, okay? So you can have a force going laterally, a force going vertically, or a force going... Is that okay? So there's
Yes,
a
lateral compression, anti-posterior compression, and vertical.
AP compression and vertical compression, okay? Or then you have a combining. Can we make sure that we have only just us guys talking? If you've got a noise in the background, can you mute yourself then, if that's okay? Yeah. So if you have a vertical compression fracture, you know, how will you manage that?
Either is stable or unstable.
So if it's a vertically unstable patient and you've seen him the A&E, how are you going to reduce that?
So for vertical unstable pressure, what we do in our setup, we just apply traction and
what? So assuming the
I think we can apply sacral bolts. That is stable.
bolt after
Sacral bolts.
You can do that, but the easiest thing is that you apply vertical traction and you put a binder on it. Okay.
Okay.
Your pelvic binder that comes like a strapping will also help you. So the only time that the binder doesn't help is when?
I think vertical shear.
No, lateral. You know, when you have lateral compression, this fracture is already moved into the other side. That's the only time it's not going to help you, and therefore you need an external fixator to reduce it and put it together. But anything else, you can reduce it and use your binder to hold it together, yeah?
yes.
Okay. So what next? I mean, what is the long-term outcome of these patients with injuries around the pelvis?
So they might develop the complications like malunions, non-unions, and
that's an open complication. What else? So you can see that this is a patient with an open book fracture. The sacroiliac joint is gone on this side, and there's a binder applied, and the whole thing is reduced very well, and the patient then stops bleeding, and they start having a very good outcome. You need to fix them. Where I've got pictures somewhere. Well, there you go. So you can put them on the ileum and do the binder used to be a good thing, but nobody uses the C-clamp purely because it's invasive and it's not complete. The binder does a lot better work now. There's some pictures, nice pictures. Yeah, this is where you need to end up. So this is called a delta configuration. If you can see it, you put one pin on each side, and then you bring it together to hold together and brings a lot more stability. Okay. If you want to make it even more stable, you can put a rod all across it also.
Yes, sir.
Okay, so let's go somewhere else. So what do you see on this X-ray that is? You can see. Hang on.
So there is slide over the
Yeah, I
screen.
understand. Just give me a second. I've got so many things open that it doesn't. Okay, so can you see it now? Yeah.
Yeah.
So you can see a picture of a knee with a patella. Yes.
Yes, sir. Yes, sir.
Yes.
Yes.
Okay, so can somebody describe what this is then? What are you seeing? I don't have a second view of it, but what do you see on this picture?
Sir, this is lateral view of skeletal view of knee of skeletally mature patient, showing the distal femur, tibia, and fibula.
But instead of saying that, it's showing the knee joint.
The most obvious,
Yeah.
what do you see? Finding I can appreciate. The most obvious finding I can appreciate is the patella, superior migration of the patella due to.
So you have a patella which is not right, okay? The patella is not right, superior migrated. Do you know of any lines you can draw here which it tells you that the patella is high?
I will draw Blumescent line.
So what's a Blumescent line?
Yes, sir.
Tell me what's a Blumescent line.
Blumescent line is along the superior along the roof of the intercondylar fossa.
Up here, yeah?
Yeah.
And so what it should do?
So it should lie with the inferior pole of the patella, I think, as far as I remember.
You should touch it, okay? So what's the other? You can draw a line from here to here, measure that distance and measure this distance.
Two lines, in cell Salvati line, I think.
Yeah. So it's also
Salvati ratio.
From here to here, and it tells you it's a high patella, isn't it? So if this person was playing football and he came to A&E with this, what do you think is wrong?
Might have ruptured the quadriceps.
Infrapatellar tendon must maybe ruptured.
Patellar tendon rupture.
Infrapatellar.
Is what, sorry?
Infrapatellar tendons are maybe ruptured due to
injury. Okay, so you have patellar ruptures, you've got a quadricep tendon rupture, and you've got a patellar ligament rupture, isn't it? So according to age, which is common, what age has what?
So the patellar tendon rupture is much more commoner in younger age group.
It is commoner in younger age group. What about fracture of the patella?
Sir, in adolescents, tibial tubercle is common in young adults.
Listen, 20s ligaments and patellae, okay, 20 to 40 patellar fractures, and 40 and above is quadricep tears, yeah? So on age you have, so in this person has, looks like a ligament and patella rupture, isn't it? How will you assess this? What is your plan of management?
Sir, plan of management is that I will this soft tissue
so there should be no blanks when you're asking exams, okay? So this is the patient who has a potential patellar tendon rupture. Clinically, it looks like it, and the X-ray confirms it. However, I would like to do an ultrasound to confirm it, okay?
Yes. Yes.
So when you've done the ultrasound, what do you do next? The ultrasound shows you that there is a patellar tendon rupture. What are you going to do now?
Sir, I would like to cerclage and repair.
So why would you want to cerclage the patellar tendon? The patella itself is not broken.
Sir, if patellar tendon is broken, I will do the not patella. I will for stability of the repair, I will go for the cerclage too.
So would you not want to reattach the tendon to the patella first?
Yes, yes. I will repair the or attach the patellar tendon, and then we'll protect the repair via cerclage.
So how are you going to do that? You can either attach it by putting drill holes through the patella and pulling it through, sutures through, or you can use anchors to bring it together. So once you've done that, then if you want to, you can put a cerclage around it to protect your repair. What's the problem with that? So if you put a cerclage around it, you won't be able to flex your knee, isn't it? Is that correct?
Yes.
So why do you want to put a cerclage around it to protect your repair? Because it's a young person, you repaired it, and you now put a cerclage around it, then the whole patient won't be able to flex his knee. So all you have to do is repair the patellar tendon, it'll work. It'll work. It'll definitely work for you, okay?
Okay, sir.
So this is a 10-year-old that's come to A&E.
Mm-hmm. 10-year-old.
This is the most common thing you see in Pakistan?
Yes,
Yes.
sir.
Supracondylar fracture.
There's an X-ray of it is X-ray of elbow joint showing the Gartner type 3, the fracture,
Okay.
supracondylar fracture of the humerus.
So is it a 3 or is it a 4?
Sir, it looks like 4 because the humerus is teasing the skin. It's coming out from the skin.
Yeah,
I think.
don't commit yourself. You know, in the exam, you will say this is an X-ray of a skeletally mature child showing in the elbow fracture. This fracture is posteriorly displaced, right? This is of the extension type. Now, if the examiner wants to ask you what Gartland classification is, then you tell them. Otherwise, you don't volunteer information that you don't have to. What is the big thing that's going to be a problem here?
Sir, brachial artery.
Yes, so you'll have a vascular problem. Okay.
Yes, sir.
So how will you assess this then? You're doing well. You just need to continue. You can't just answer.
Sir, when the patient came to us, I take a brief history. Then I will check the distal pulses whether I am getting radial and ulnar pulses or not. If yes, then I'm going to reduce maintain the IV line. I will reduce it under anesthesia, and then will observe the return of the pulse if patient is not having the pulses.
If it is not coming, the pulse is not coming, what will you do?
So we will go for CT angiogram, or we will open it and then.
All you guys in Pakistan do not like help, you know. In my country,
I will reduce.
Yes, we have help. I'm sure that brachial artery is damaged or caught. So every time I take somebody like this to theater, I will ask the vascular surgeons to come with me. Right? Does anybody know how to get to the brachial artery?
Yes, sir. I know, sir. The anti-approach elbow.
Okay. How many times have you done that?
Sir, never.
Yeah. So why do you want to go to theater without doing anything that you've ever done before? So the safe answer to the exam is...
If the pulses are not palpable, I will remanipulate the fracture and then recheck the pulses again.
Okay, so it's still not coming.
Sir, I will check for the capillary refill. If capillary refill is okay, sometimes they don't possess not, but the clinical condition of the clinical condition of the hand is
absolutely right. There's nothing wrong with that. But look at this X-ray again. Do you think that the brachial artery is intact?
Sir, I will assess if there is expanding hematoma.
Yes. So you don't have to say these things in the exam. What you have to say in this exam is this is an extension type supracondylar fracture in a skeletally immature person. I would try to reduce this patient and see if I can bring it back in A&E. If I can't bring the pulses back again, I will do what is called a capillary refill. If that is not good, I will ask my vascular colleague to come and help me while I'm trying to stabilize this. So what are you going to do then? So you've asked your vascular colleague. Yes?
Yes, sir.
Yes, and he has come and helped you, but how are you going to help him?
Sir, after reduction, he will explore the brachial artery.
Sir, ये तो मतलब मजा नहीं है ना 2 हफ्ते रह गए हैं अब कभी क्या करोगे कभी you need to have a very good standard answer. So what you will do is you will open or ask a vascular colleague to open this fracture anteriorly. What is he going to do then? He's going to bypass the vessel for you. So he's going to put a clamp into both vessel ends and hold it for you while you then stabilize the patient, whether you want to put pins across it or you want to put it on an external fixator, whatever you want to do it, it's your choice. Once you've stabilized it, then
what we are
to repair the vessel.
For interruption, what you are confusing, it depends upon the time passed, how much time has been passed between intervention and injury.
Okay, so this will lead to my second question. Once you have now repaired the vessel, and you've reduced the fracture, what is the most important compulsory next step that you have to do?
Fasciotomy.
All of these patients who have had a potential vascular injury should have a prophylactic fasciotomy after surgery. Okay? Most students do well, right? If you see somebody 6 days later.
Sir, can I answer?
Yes.
Fasciotomy, sir.
I didn't hear your question, Satish.
Yeah.
What was your question?
Right. One question, sir.
Yes.
Department. Do we need to reduce this fracture in the ER, or directly we should go to theater for close reduction?
Okay, so in A&E, you should at least flex the elbow and see if the vessel comes back. Okay, so if you flex the elbow and your capillary fill is okay, then you have bought yourself time. But if it's not happening, then you get your vascular surgeon, you go and take the patient to theater. The vascular surgeon will actually bypass the vessel for you. He will do an anterior approach, and he will put a tube between the two ends of the vessels that is damaged and get out of the way. You then stabilize the injury for him by reducing it from the front, pulling it back in where it should go, and then you put wires across it. Once you have stabilized it, the vascular surgeon will then go and reanastomose the vessels that is torn to bring it back. At the moment, you have circulation because it's bypassed it with one of those tubes for you. Once that is done, then you will do a prophylactic fasciotomy for all these patients. Okay? Is that okay?
Yes, sir.
Okay. So tell me, you didn't tell me the Gartland's classification. So everybody was talking about Gartland. So what is Gartland's classification?
Okay, sir. Yes, sir. Clear, sir.
Okay. So what is the Gartland's classification?
So Gartland classification is for supracondylar fractures. There are 4 groups. The type 1 is undisplaced fracture. Type 2 is the minimally displaced fracture in which posterior hinge is intact.
Good.
Type 3 is type 4 is completely displaced fracture, but with intact periosteum. And in type 4, there is torn periosteum, so there is no contact between the 2 segments.
Okay, so I'm a very bad examiner. So did Gartland describe 4 parts? Did he describe the 4
there are 3 types of Gartland, as the brother mentioned. Type 4, written in some books, that is posterior-lateral or posterior-medial displacement.
No, he actually described 3 parts.
Yes, absolutely. So there is a modification of the Gartland's classification where the 4th type is come in. So in the exam, if somebody says, how many Gartland's types, you will say there are 3 types. There is a modification where the 4th type is come in. What is the difference between a 3 and a 4? For you?
That will tell us whether the fragment is posterior-lateral or posterior-medial.
Yes, it is. There is no hinge at all, right? The periosteum is gone totally in 4, whereas there is periosteum still intact in 3s. So what is difference does that make for you?
Sir, Gartland type 4 fractures are totally unstable.
Yes, so?
Sir, there is little
need.
So, okay, listen to this now. You need a periosteum to manipulate the distal humerus closed. If you don't have a periosteum, you can never reduce this closed. Okay?
Yes, sir.
Because you have no hinge to reduce it onto. So that comes to the question is, if you have to open to reduce the supracondylar fracture, how do you do it?
Sir, I will approach from the medial side. I will explore.
Why?
Okay. Sir, from medial side, first of all, I will explore the ulna.
Yes.
And protect it. I will reach the humerus in the interval between brachialis and tricep, and will reduce the fracture.
And then?
After reduction, I will pass 2 or 3 wires to hold my reduction.
Okay, so the best paper that everybody accepts is from Clark et al. in Southampton. They are the pediatric unit, and he's now Professor Clark, but he wasn't professor when he wrote it up. He has said that you have to have a 1.6 millimeter K wire the KYs should be both sides, lateral and medial. They should cross each other, but not at the fracture side. Are we clear on that? Yeah? So if somebody asks you in the exam, you will say, I will reduce the supracondylar fracture, open or close. Once I've reduced it, I will flex the elbow and supinate the hand. Once I've done that, I will pass 2 KYs. I will bind it to the ulnar nerve first. So I will make a small little approach on the medial side to make sure I know I'm not touching the ulnar nerve. The wires will be 1.6 millimeter. They should actually hold both pillars, and they should not cross at the side of the fracture.
Yes.
Okay, supracondylar fracture, done and dusted. Remember, if you have a vascular injury, you have to do a prophylactic fasciotomy every time.
Oh yeah, right, sir.
Yeah, that's a nice one. So what's this? This is a gentleman who came in with a dislocated shoulder following a road traffic accident. Okay, when he came in, there was a lot more than a dislocation, but this is what it was. This gentleman was 45 years old. This is a right-hand dominant. He's a farmer by profession, and he came with injury like this.
Okay.
Fracture dislocation of the proximal humerus looks to be comminuted and 4-part type. I need further views to confirm findings.
That's a very good answer. I don't have further views, but you're right. Describe Neer's classification. How does it say that there are 4 parts? Is there a method of saying 4 parts?
2 parts.
Yes,
That's
Neer describes proximal humerus fracture. Yes, there are 4 parts. One is head, second is shaft. Yes, we have 4 parts. One is head, shaft, leather, and greater tuberosity.
Yes.
And
what else did he say? He said it has to be a centimeter apart. And how many degrees away?
So 10 degrees and 2 centimeters apart.
2 millimeters and 45 degrees.
Yes.
45 degrees.
Where is the tuberosity? Where it should be?
Yes, so that's one.
But look at the humeral top. Is it where it should be?
No.
Yes, it is. Look at where it is. It should be where it is. So it is not a 4-part fracture because the tuberosity and the humeral shaft are where it is.
No.
Only the humeral head has gone away. But that's not described as 4-part fracture.
It's 2-part fracture.
So what is this?
It's a 3-part in my view.
No.
One is tuberosity, second is humerus, third is head.
Yes, this is a fracture dislocation, which was type 5 of the Neer's classification. Do you remember that? So you don't have to worry about the 4-part. This is the fracture dislocation.
Yes, type 5. Type 5 includes the dislocation as well.
Yes. Is this a fracture dislocation?
Yes, sir.
So what is now the classification? It's a 4-part or is it a fracture dislocation?
It is fracture dislocation.
Great. See, you all know this, but you don't want to say this. I don't know why. Like I said, you know all this. So how are you going to manage this in a 45-year-old?
Open reduction, internal fixation.
Yes, that
with Philos plate.
That is what a medical student will tell me also, isn't it?
So with Philos plate.
Sorry?
So Philos plate.
Okay, but what about this humeral head?
So we are going to reduce it.
Yes, but there is a high chance that this is going to have AVN, isn't it?
Yes, sir. Yes, sir.
So if you are above the age of 65, remember we said 65 was a golden word. You could actually go and replace this because this is going to die.
Yes, sir.
Right, but if it's below the age of 65,
45, yes, sir.
You have to put a plate on it and reduce this and put the head on. Even though if he has or she has AVN, the head will still be solid like an ivory, so they will have joint, and you can come back later on in life and do something else with it. But with the young person, you have to reduce it and plate it and put it all together. Okay, you don't have to use Philos plate by the name. You can just say you reduce it and put a plate on it.
Okay.
Worry concern is that headpiece is going to be AVN. Okay. So
yes, sir.
keep an eye on this person and make sure that you don't miss him in the follow-up here. So are we clear now? This is not a 4-part fracture. This is a fracture dislocation.
Yes, sir.
To be 4-part, all 4 parts should be 45 degrees and a centimeter apart. Yeah. So each part has to follow that definition. Yeah. Otherwise, it's not. So how many people agree on the Neer's classification? Does anybody know?
Yes, it is.
Called inter-observer and intra-observer.
Sir, part one is non-displaced or minimally displaced fracture.
No. We've gone back to this. You're saying the same thing again. There's no minimal displaced. One bit is moved from where it should be. It should be a centimeter away and 45 degrees.
The one part should be 1 centimeter apart and 45 degrees
yeah,
angulated.
Any bit, whether it's a tuberosity, lesser tuberosity, greater tuberosity, or head. So that becomes a two-part fracture then, yeah? The three-part fracture is when all 3 bits, tuberosity, head, and shaft is moved away and you have a centimeter and 45 degrees. You have to have those parameters to describe them. Otherwise, they're not 2-part, 3-part fractures. They have to be so many centimeters away and so many degrees angulated. Okay?
Yeah.
So, okay. So coming back again now, what is intra-observer and inter-observer agreement?
Sir, intra-observer reliability means when a single person classifies some fracture, and after some time, a same person classifies the same fracture.
Very good.
And we assess the intra-observer variation.
Yeah, and inter-observer is when 2 people describe it separately, like you said.
Yes, sir.
The study that was done in London not so long ago, and there was a 45% inter and a 40% intra-observer agreement between NIRC's classification. So the same person who classified it did not agree with his own classification when he was asked to do it again. So this is a very poor classification for understanding what is happening. Why do we do this NIRC's classification?
Dictates the treatment protocol, actually.
Yes, it predicts what you can do and what the long-term outcome for your management is. That's why we use it. Otherwise, not a lot of people agree on to it, isn't it? We've done that before.
Exactly.
Okay, here.
Excuse me, sir?
Yes.
So can we put this fracture dislocation in NIRC classification, or we should not?
No. So you will say this is a fracture dislocation of the proximal humerus. Okay, with the head separated, there's a coronal split on the head. Now, the examiner says, what about NIRC classification? We say this is type 5 because it's a fracture dislocation.
Okay.
Okay, sir.
You don't talk about, 2-part, 3-part, 4-part because it is dislocated. So by automatic choice, that is a fracture dislocation. You don't have to then classify whether it's 2-part, 3-part, or 4-part. He specifically said in his 5th part that this is a fracture dislocation.
Right, sir.
Okay, so this is a 42-year-old, 43-year-old, I don't remember, like this. He turned up after the horse. He fell from a horse while he was horse riding, and then the horse was, I think it fell on top of him, something like that. So he came in with a swollen bruised knee. This is the X-ray that was taken in the A&E.
Okay. So first of all, I'll describe this X-ray. This is a X-ray knee APL lateral view of skeletally mature patient.
Yes.
Showing a highly comminuted tibial plate to fracture. That can be classified as Schatzker type 6.
Okay. So there's discontinuity.
And there is yes, sir. Look like there is discontinuity between the epiphysis and metaphysis, diaphysis.
And the classification Schatzkers that you know of.
Yes, sir.
Which one is that?
Sir, Holland-Moore.
Yeah, there's a Chinese classification. You know that one, where it is classified tibia.
That look like coronal split, something like that.
Pillars. There is an interior one. There's a lateral and a medial one, and there's a posterior one. Okay. Why is Schatzker classification not so good?
Sir, because it doesn't include the coronal splits.
Yes, and the other thing is that when the Schatzker's classification was done, there was only 23 patients in the study. So if you have 6 classifications and you have only 23 patients, can you imagine how many patients would in each study? Okay, so it says, unfortunately, it stood the test of time. We are still talking about Schatzker's when it does not do our job for us. But there is a better classification, which the Chinese, I think it's a Zio or Zin classification, whatever it's called, but it describes them into to lateral, medial, and posterior pillars. Okay, and it describes the whole thing for you, and it also gives you management. But in the exam, unfortunately, you have to stick to Schatzker's classification because all the examiners will be talking about it. Okay?
Yes.
So what next?
Okay. Sir, I want detailed history and examination, especially examination for the possible compartment syndrome in this patient.
Right.
I will also look for a possible foot drop in this patient as he has associated fibular neck fracture as well.
Okay, so absolutely fantastic, but you have to say this in the exam whether you like it or not. I will first do
Sir, actually, we need hip and ankle X-rays too.
Yes, but you need to say this in the exam that you have to make sure that this patient is ATLS triaged and stabilized, because these patients fallen from a horse, he may have other injuries, isn't it?
Okay, sir. Yeah.
Okay, so if you haven't said it, the examiner doesn't know, so he thinks you don't know. Okay, make sure that you say all the basic things. If you have to see a trauma patient, you have to talk about ATLS. You will say, assuming that this patient is ATLS triaged, he is stable, this is an isolated injury. I think this is an injury. In my view, the X-ray is showing a proximal tibia fracture, which is discontinued from the bone itself. So then the examiner will say, what do you think it is? Well, so there are, according to the Schatzki's classification, this is a type 6 because there's discontinuity, okay? Okay, so let's go one step back. Will you fix all lateral pillar fractures or lateral column fractures?
Yes, we do.
No. You fix all,
We had to.
Depending upon
all medium column fractures. Why?
Because the weight bearing is actually majority of weight bearing is going through the medial joint line.
Your line of force passes posterior medial to the tibia. So if you even have an undisplaced posterior tibial or medial side fracture, the weight bearing will displace it. So every medial side tibial plateau fractures are fixed. Okay. What about the lateral side?
If it is undisplaced sort of fracture or low energy velocity injury, we can manage it non-operatively.
Okay, so you must remember the rule of 5. 5 degrees of valgus on assessing EUA, 5 degrees of slip, 5 millimeters of depression. These patients will be fixed. Anything less than that, leave them alone. So when you evenly them, they open more than 5 degrees, or the tibial plateau is 5 millimeter depressed, or there is a 5 degree angulation in them, you will fix them. Anything less than that, you can leave them and manage them non-operatively. Okay?
Right.
So remember this. This is important because you can't fix everything. Okay. So what other reasons do you not?
5 degrees.
5 millimeter depression, 5 degrees of angulation, and 5 degrees when you EUA them, they open valgus. Yeah.
Okay. Thank you.
Okay. So what will you do next with this person now? You can see it on
after stabilization. I'll go for an MRI in this case.
Why MRI?
CT scan.
No. Let's talk to the person who wants to do an MRI first. Why do you want an MRI scan?
Because there are chances of soft tissue injuries, and 50 to 90% of these sort of the fractures are associated with soft tissue injuries.
Absolutely correct.
Particularly the MCL and ACL and MCL. The ACL is involved in around 50% of cases.
Like to do a bone window first, so you'd like to do a CT scan first. Once you've done the CT scan and then you decide to do something with it, before you fix the person, then you ask for an MRI scan. But initial investigation, gold standard for all these patients is you do a CT scan first. Once you have done a CT scan first, when you plan further management, then you do an MRI scan to make sure when you put in plates or anything on these patients that you are not missing out soft tissue injuries. Even if you miss out soft tissue injuries, it is okay. You can always come back and fix it. But once you put metal on it, the MRI scan will not show them to you.
Exactly, sir.
Okay, so you will do a CT scan first. Before you plan to fix them, you want to do an MRI scan.
Okay.
Excuse me, sir.
Yeah.
Excuse me, sir.
Yes.
Sir, actually, I wanted to ask, what about the trend of 3D printing? Is it common there in UK, or just we are just
very
going through?
It's very expensive. I will show you something actually.
I was surprised to see on Instagram and on different forums that people even going toward this way.
We're all digressing now. This is the patient of mine. Can you see? Okay.
Yes, sir.
I don't know what's happening. Just give me a minute. So can you see this?
And sir, yes. Yes. How much is cost, sir?
This is a 3D printing of a scapula for a patient of mine that was having revision surgery. So if you can see, there is the whole of the scapula has been printed for me. Okay. So once the scapula is printed for me, they've also then printed me a 3D of the implant that I'm going to put in the patient. Okay. So this is where if you can see that, it is going to where the coracoid is. Yeah. It goes under the coracoid and it fits onto the patient like that. Can you see it?
Okay. Okay.
Then I can put a wire here, and this is my ultimate implant that will go in. This is the replacement of the shoulder with a glenoid component that a 3D has been done for me. So yes, we do have 3D, but it's bloody expensive. So this particular bits that.
So how much cost? How much cost?
So this to do a revision to have these done is £7,000.
Oh my God.
Okay, so we do have
carry on.
one, but we have to have special permission from the health authorities, from the local, the GPs and the local authorities to give us money to it. But yes, we do them.
Okay.
But why do you want a 3D for you? You want a 3D printing? Yeah, so you know what to fix. That's a very good idea. A lot of surgeons do that. But unfortunately, it's still in its infancy. Okay, going. So how are you going to manage this now? How are we managing this?
Sir,
So we
Sir,
have
I
to
would-
we
Can I suggest
reconstruct
something?
the.
Why don't we do this on rotation? Everybody has to learn how to speak. All of you know the information. You don't know how to speak. So can we do this by rotation rather than everybody speaking all the time? Okay. So can we start with whoever wants to start first? Tell me the management plan for this then. This is a patient who's come in. You've done a CT scan. There is no soft tissue injury on the MRI scan. This patient you have to see. So what will you do with this patient?
So assuming it is an isolated injury, I will plane its open reduction and internal fixation, and according to the 3-column theory, I have to maintain. I have to reconstruct his lateral medial and posteromedial pillar with open
Okay, so
reduction.
very good. However, do you think you would be able to fix this?
It is difficult, yes. There's a
What are
lot
your
of
other
bone
options?
loss.
What are your other options? You live in a country where everybody uses this.
Sir, I will go
You're talking
with the primary bone graft.
No. Nobody does bone grafting primarily in Pakistan. What is the most common thing that people do with an injury like this in Pakistan?
So external fixator, spanning of the external fixator.
And so everybody does Alice-Roth, isn't it? It's a common thing, isn't it? This is a totally destroyed knee. It is not going to go back to normal with all your plates and bone grafting. It's going to be abnormal totally, isn't it? So you will do an external fixator such as the Alice-Roth management for these complex fractures, okay? So
Okay.
if you don't know how to do an Alice-Roth fracture, plate frames, what are you going to do with this?
Sir, sorry, I couldn't heard.
So when you see a patient like this, you cannot reconstruct this, okay? You know that when you manage patients, you actually repair, reconstruct, or replace, okay? Once you can't do these three things, before replace and after reconstruct is salvage. So this is now in the domain of salvage surgery. So the salvage surgery for this patient would be to put a Alice-Roth frame on. Is that agreed?
Okay.
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 So if you don't know how to put an Alice-Roth frame, somebody like me who does not know anything at all, like this, what am I going to do with this?
So spanning external fixator.
Okay. So in the exam, the word you're going to use is span.
AOX. AOX.
You span it. You scan it.
Okay.
You span it. Do you understand the
You
words?
plan it.
Span it.
Yeah.
Yes. You span it. You scan it and then you plan it.
Okay.
Okay.
So what you do is you put a spanning fixator across it. You send for test and various whatever you want to do. You can do an MRI and CT also and that. And then you plan it. And the plan means either you do the definitive fixation yourself or you ask a colleague to come and help you.
Okay.
Okay.
I'm not sure about Pakistan, but in England, not everybody can put the Alice-Roth frames. Not many people can do it. Okay, there are only special centers that do it, and therefore, in a patient like this, we have to send them. So when I work near Birmingham, so we have to send them to the QE, and there are 3 people who do fixators and for us. Okay.
Sir, in our setup, we apply uniplanars X-Pix, and later on we reconstruct.
Yeah, so that's called spanning it, isn't it? You're putting a spanner on it by spanning the joint. Okay?
Yeah.
And it gives you time to scan it. So you do the CT scans and you do the MRI scans or whatever you want to do. And then you plan the ultimate management for this patient, whether you want to do it yourself or you want a colleague to help you. So remember these 3 words. It looks very posh and very professional when you say in the exam is I will span this fracture. I will then scan it and then I will plan it. Okay, it looks very, very nice to say that in the exam, yeah? But these are the words you have to use. Okay, so this needs an Alizarov frame. This is a very complicated fracture. I don't think so you'll be able to fix this, put plates on it and whatever. What's a bone metal sandwich? This is another thing that people talk about in the exams in this country. What's a bone metal sandwich?
Excuse me, sir, but I do Ilizarov for such a patients. But if there is so much communication and so much step is there, then Ilizarov become difficult. Even those who are doing Ilizarov, even they will think of doing bilateral plate, bicolumn plate.
Yes.
So sometimes Ilizarov is not optional for the step if so much communication is there on articular surface.
Absolutely right. But
that is sometimes difficult to address.
What we have
pins in. You can put plates in there and do an Alizarov on it. You can bone graft it and put an Alizarov on it, but you can use augmented with an Alizarov. I do not think, personally, I mean, I could be totally wrong, but this is, we put a, well, okay, so I don't do Alizarovs. So I do what is called a hybrid fixator. I would put a ring here and then put pins in the tibia. That's what I do. Okay, in this patient,
in this particular case, the posterior condyle is very difficult.
Yeah,
you
have to fix it.
Very difficult.
You can, you know, the Alizarov has got olives on it, and you can pull everything back. So in this particular case, we used 3 pins, and 2 of them were with olives, and we pulled it back, but we filled the middle, the whole of it, with bone graft. This was all filled with bone graft, and we used. Yeah.
Sir, you remember I showed you the case today. That was a knee joint X-ray and there was a tibia fracture.
Yeah.
So that patient, I did a nailing of tibia, close nailing. But during follow-up, it was very surprising to me that there was a fracture of femoral condyle. Very, very strange and very difficult fracture. So that I was missed. So only if you carefully see the X-ray, there was a minor crack only visible on the distal femur. But follow-up, it was terrible. It was terrible when it came back.
You have to do a
me.
little survey. But this patient had a ring fixator with olives to reduce the fracture. Some extra plate was put in and bone grafted it to make it. This person's knee is never going to be normal. So, you know, you have to make the best of the worst situations. Yeah, let's do this. This is what people fail and pass an exam. So this is a 79-year-old who's come in. She was found on the floor by her carer, and she could not weight bear. Before that, she was fully mobile and had no problems. So what do you think this is?
So this is
talking to me last. Was it Noor you were talking to me last? Is it?
Neck of femur fracture.
Who wants
this
to
is X-ray up.
Who's talking to me? Can I just know? Because I've got about 10 of you and I don't know who's talking to me now. It's still you're talking, Noor, yeah?
Yes, sir. It's a neck of femur fracture.
So in an exam, if you want to be a consultant, you tell me that. Tell me will I pass you or not.
So it is.
So this is X-ray with showing the
acetabulum fracture.
Please, okay. So Maqsood wants to say something. Let Maqsood say then, okay.
It's a neck of femur fracture, and even the ilio, and there it looks like an acetabular fracture too. I think.
Yeah, okay. Don't worry about these things. This is just incidental finding. Okay, so
fine.
This is an X-ray AP of a skeletally mature person with an intracapsular neck of femur. Okay, you can't just say this is neck of femur fracture. A medical student will tell me that. So this is a intracapsular neck of femur fracture. Okay, forget this.
Okay.
Okay, forget the acetabular. Just it's an intracapsular neck of femur. Right. So what do you think this is? What type of neck of femur is this? Do you know of any classification of neck of femurs?
It's Gardner classification.
Okay, so what's a Gardner classification?
So type 1, Gardner type 1 is a valgus impacted fracture.
Okay.
Incomplete valgus impacted.
Okay.
Type 2 is a complete fracture.
Right.
And type 3.
The type 3 has perpendicular trabecular patterns, and type 4 have the parallel trabecular pattern to the neck.
With the acetabulum.
Does that help you in your mind? No. So in the exam, I would use the Powell's classification. You know what a Powell's classification is?
Yes, sir. The Powell's classification.
So I don't want all of you to rush in. See, I'm great. I'm happy that all of you are not talking. Before that, when I first started, nobody was talking. So the good thing is that you have to talk. You can't pass exams without talking. So I'm happy. But now you're all talking all at the same time. So can we just do it by turn so everybody can have a chance to say? So who's speaking? Was it Noor or was it Maqsood?
Sir, me, sir. So the Ball classification is basically give an idea about the shearing forces placed across the fracture, and it's 30 degrees, 50 degrees, and 70 degrees.
From
70
what?
degrees. The type 1 is type 1.
No, not type 1. There is 30, 40. You're right. Where are you measuring these from?
So it's from the femoral.
Horizontal.
So where are you drawing your lines?
Sir, we are measuring from the fracture line from the head of the femur.
Very good. Okay. So why is that important?
Center of head to the
Sir, to see the shearing forces applying or transferring from head to the neck of the.
So what's the best thing to do if I decide to fix this with screws? What is the best thing I want to do with this?
You have to make the fracture transverse oriented.
You want to make the forces convert into compression rather than into tension, isn't it?
Tensile, yes.
Yes. So you want to make sure that when you fix this, if you want to fix this, the forces are in compression, not in tension. What does tension and compression mean?
So when the forces are in compression direction, there is osteoblastic activity along the fracture site and high chances of healing. But when the forces on in tension side, usually there is a osteoclastic activity and the fracture tend to get into non-union and failure.
Okay, so you need to make sure that the forces are in compression rather than tension. Okay, so if I was going to see this patient and this was say like a 60-year-old, what would I do with this? I would fix them with preserving the head by putting some screws across it to make sure that when the forces were visible when we fixed it, that they were in compression, not in tension. Okay, so how will you predict that this person is going to have more fractures in the future or not?
So there's Sinks classification.
What classification?
The
Sinks index.
Yeah, Sinks index only tells you where the forces are going. It doesn't tell you it's going to have fractures in the future.
So we go for DEXA scan.
So you go for a DEXA scan, which is very clever. Yeah, it will give you two values. What values will it give you?
The T-score.
The T-score and Z-score.
Okay, so what's a T-score and what's a Z-score?
So T-score is compared with T-score is compared with the same age group, and Z-score is compared with the age of 25 for male.
So the T-score or Z-score, you got it wrong. T-score is when you have maximum bone mass, which is at the age of 25 to 30. So that's a T-score. So if you need to measure the patient scores and put it on the graph into standard deviation where there's a T-score. Okay. However, the Z-score is matched for age and sex of the person. Okay. So you need to know T-score and Z-score. So T-score will tell you whether the person has osteopenia or not. Okay. The person, if it's 2.5 standard deviation, becomes osteoporotic. So how will you know that this person is going to have a fracture in the future?
I will assess the T-score.
The T-score doesn't tell you if a fracture in the future.
So if
you know anything about the FRAX system? F-R-A-X-K, FRAX system.
So just listen now, FRAX system.
Yeah, so what it is there is a computer scoring system where you put the Z-score, the patient's comorbidities, and the various other ages and whatever on this. It's a computer system score, it's a software. It will then predict whether the person is going to have fractures in the future or not. It's called a FRAX system. Okay? How would you know that this person is going to live long or is going to have a mortality in the future?
Sir, it is said that if a person has a fracture of NOF fracture, if it is not treated, he has a morbidity of about 1 year. Mein uski wo ho jati hai.
Fine, you've treated them now. How will you know that this patient is going to survive?
if you are able to fix them and he is mobile, the morbidity chances, morbidity and chances become much lower.
No, but there is system. Exam you need to know. There is called the Nottingham scoring system. In the Nottingham scoring system, you put the age of the patient, you put all the comorbidities and everything, and it will predict you survival rate. It will tell you how many people will survive in the next year or so. Okay, so what is called the Nottingham predictive value, Nottingham scoring system. You need to know that. You need to go on the internet. If I have a picture, I'll send it I'll post it on the system. But there is a Nottingham score to tell you the person's mortality. And there is a FRAC system which tells you how many fractures they're going to have in the future. Okay, these are the two things you need to know if you're dealing with patients with neck of femur. Unfortunately, all your examiners have been to England and back again, and they will ask you this question.
Yes, Nottingham. FRAC system and Nottingham system.
Oh, yeah, you need to know that, yeah?
Yes.
One more, and then we'll come back tomorrow morning, yeah, if that's okay.
This is it.
Yes.
Yeah, this. Now, let's do this. No, I don't want to do this. What's MEST scoring system?
Mangle extremity severity scoring system.
What's that?
It determines the soft tissue injury of the limb and predict the outcome of whether the salvage or salvage will be successful or you need to go for it.
It is basically a decision to make whether you can salvage a leg or not, isn't it? That's what it's called. Yes. It is dependent on relative ischemia, the blood pressure, the time from where the accident done, and this soft tissue damage. Is that correct?
And also the age.
So what is it? What is the MEST? How will you calculate somebody's MEST?
So there are four groups. You need to take the age of patient. If it's less than 30, it's 1. More than 30, it's 2.
Now, in the exam, you will say that this is a scoring system to tell you whether you want to have a limb that can be salvaged or not. It is based on relative ischemia time, the blood pressure of the patient, the age of the patient, and the duration from the time of the injury. Okay? And the various scoring system will tell you what's happening. You have to be very quick and very general. If you start classifying it, you will not be able to answer any questions at all. Like, what is this? This is a right-hand dominant gentleman with a fracture of the proximity. What do you see?
It's showing greater tuberosity avulsion fracture.
And what type of fracture would the nearest classification this be?
I think it's 1.
What, sorry?
Type
It can't be
one
one.
part.
There can't be one.
One part.
There's no one bone broken. There are two. Always there's a two. Minimum two.
Two parts, sorry.
Three parts.
Perfect.
Yeah,
Three
so-
parts.
so what's the problem with these? How will you manage this?
We have to fix it
Why?
because there are high chances of non-union because of the attachment of the muscle, rotator cuff muscle.
Rotator cuff muscle.
Yeah, the supraspinatus is attached to it. So this is not a tuberosity fracture, but it's a supraspinatus tear. The bone is attached to it. The reason this doesn't work is the supraspinatus doesn't function because it's pulling the tuberosity, and therefore you have no supraspinatus. So what is the function of supraspinatus in the shoulder?
Actually, it depresses the shoulder joint.
Very good. It puts the shoulder back into the socket. So when the shoulder is back into the socket, then it allows you to do all the functions with the deltoid, isn't it, and every other comfort. So this is a very particular X-ray. You will see this in the exam, and they will ask you what this is.
Yes.
This is a patient who's come up after falling from a bicycle and has now got a radial nerve palsy.
Yes. This is X-ray showing long spiral fracture of distal shaft of humerus. So as it is associated with the radial nerve palsy, so we have to classify it as a holistic nerve fracture.
So what's the name for this?
Holstein.
Holstein Lewis.
Yes. What does that mean?
This.
What does Lewis fracture mean?
In this
spiral groove.
The nerve is damaged in it, isn't it? The nerve has got injured. So if you have no nerve injury and you operate on somebody and they have radial nerve palsy, what is the management for that? And if you have radial nerve problem before you've done surgery, how you manage those? So let's go with the patients who have got radial nerve palsy and you've seen them and it's an undisplaced fracture. What are you going to do with those people?
We have to observe them. We have to observe them.
How long will you observe them?
For 3 months.
That's quite a lot of time, isn't it? 3 months you can't do anything.
6
So
weeks.
when will the nerve conduction show you something is wrong with the person? How soon can nerve conduction pick a problem with the nerve?
Within 10 days.
No. Where did you read that? I may be wrong, but where did you read that?
3 weeks, I think.
6 weeks.
2 days.
No,
3
6
weeks.
weeks. It takes 6 weeks for the nerve conduction to pick problems with nerves. Okay? Why is that? If a nerve is damaged, what happens then?
Within degeneration.
Valent degeneration.
Or what? To the node above it, to the node below, isn't it? Right? It takes about 6 weeks before it presents itself on a nerve conduction problem with a delay and a missing and absent nerve. So if you want to manage somebody non-operatively, you have to do a nerve conduction study at 6 weeks to make sure that the nerve is intact and functioning before you decide not to do anything with it. If at 6 weeks the nerve is showing no function at all, then you need to explore it at the time. Okay? What about if you have operated this patient, put a plate on it, and now he's got a nerve problem? What are you going to do now?
We have to open it. We have to open
explore
and
it straight away.
Yes, straightforward. Sir,
Yeah.
the X-ray of the tuberosity fracture that you showed to us, why we are saying it's near part, 2-part fracture?
There is no 1-part fracture. You have to have 2 bones to make it 2-part.
It's not displaced more than 45 degree or 1.
It is. So for a tuberosity fracture, you don't go to 1 centimeter and 45 degrees angulation. The reason for that is the supraspinatus is attached to it. So relatively, it's a supraspinatus tear rather than tuberosity function. So it does not come into the NAERS classification as such. However, you will have to treat the tuberosity fracture as separate entity from the fractures around the proximal because supraspinatus is attached to it. It is not considered as a fracture, but it's considered as a malfunction of the supraspinatus tendon. Okay?
Okay, sir. So there is a role of any trabecules alignment on this X-ray, please.
What, sorry?
Alignment of trabecular bones in this
in this fracture.
Yeah.
It doesn't matter because if the tuberosity is gone completely, then the supraspinatus is not working, so you have to fix them. It doesn't matter how far it's gone. Either you don't fix them and keep seeing them every week, or you just go and fix them. How are you going to fix this actually? Sorry, I forgot to ask you that.
Sir, you can do it hello?
Percutaneous screw fixation.
So this is an osteopenic bone. You know, it's broken just from somebody falling off. Do you think a screw is going to hold it?
No, you have to buttress it with the plate.
Yeah, so the most strongest part of this bone is the supraspinatus tendon. So you have to fix these by putting a stitch through the supraspinatus tendon, okay? And do what is called a figure of 8 or a tension banding of it. So it goes through the supraspinatus and come, and you can then make a hole in the humerus and go through it, or you can put a screw here and put the figure of 8 around the 8. But this screw is not going to hold it because this is an osteopenic bone. It will fracture. The problem is that supraspinatus is tensioning. So you need to put the supraspinatus back on. So you put a suture through the supraspinatus and bring it down and attach it. The tuberosity will come with it.
Okay.
So what will be the post-op position of this?
The post-op is like a supraspinatus tendon repair. So for the first 2 weeks, they are left alone only circumduction and gravity-assisted exercises for the humeral head. After 2 weeks, then you start doing one range of motion exercise in one plane. So you can either flex them or embed them, but not a complex. At 4 weeks to 6 weeks, then you start doing more things with them, and then you do activities of normal living at that time.
Okay.
Okay, so this is a radial head fracture. Does anybody know any classification of radial head fractures?
Yes, sir. Mason classification.
Mason 3.
So type 1 is
So there are
comminuted fractures.
So there are 4 groups. Type 1 is undisplaced. Type 2 is displaced. Type 3 is comminuted, and 4 is with elbow joint instability.
Okay. So obviously this is on the table. The picture is taken on the table. But do you know any ways of fixing these radial head fractures?
Yes.
So you can either put screws across them, or you can put a plate on it.
Yes,
Okay.
on the non-articular side.
Screws.
That's the next.
Yes.
What's the save zone on the radial head then?
That's between the 90 degree between the radial styloid and Lister tubercle.
I didn't hear you. Sorry. What are you going to do? 90 degrees of what?
90 degree from the safe zone is from the 90 degree from the Lister tubercle to the radial styloid.
So what position should your hand be in when you're fixing these fractures?
Pronation.
I think it's
Prone
pronation.
position. Prone position.
You need to make,
prevent.
yeah, so
prevent
there is a
injury.
zone of about 30 degrees where you can put a plate and screws into them. Like I said, you should be in a neutral position rather than a prone position. And you fix them, and before you complete them, you want to make sure that when you rotate them that they're not catching anything. Okay, can you take a radial head off primarily?
No, sir. We should not.
Why?
To prevent the SS locostelia.
So that's a very old name. It's expressly. What's the new name for it?
Aldo.
L-root, anterior longitudinal radioulnar dissociation.
Very good.
Yes.
So you cannot, there is no investigation in the world which will tell you that the interosseous membrane is torn. Whether you do an ultrasound or MRI scan, there is no way to tell. So if you have a radial head fracture and somebody sees a radial fracture, what is the plan of management for those patients then? You will do what?
Sir, we will fix the processes and then we will remove when the after 6 weeks when the membrane get settled,
So what
get
I would
repaired.
suggest is the exam answer is you will assess the patient before you take the patient to surgery. You are either operable or non-operable. If they are operable, then you take them and consent them for fixing them with either screws or plate. If they're non-operable, then you take the hematoma out and inject the radial head. And if they can prosupinate acceptable position, you leave them alone and you bring them back in 6 weeks' time to take a planned excision of the radial head. Okay? If the patient is not able to prosupinate with the local anesthetic and it's not reconstructible, then what you do?
You have to replace it.
And you put a radial head replacement in there. The long-term outcome for radial head replacement is not very good. It becomes like an overstuffed joint. So I don't put radial head fixation unless I have to, and if I do, I take them out in 3 months' time, all of them. Yes.
You do it electively. You remove it.
Yes, because they have a lot of problems in the future. They have a complete softening of where it's touching the condyle on the humerus and cause a lot more problems. So it is not something that I like. I don't like putting radial heads in, but if I have to, then I prophylactically plan them to take them out.
Okay.
Sir, what about
Yeah.
Sir, what about the late longitudinal instability after removal of the head?
It doesn't happen. If you have left them for 6 weeks, then it doesn't happen. If you leave them longer than, if you take them out before the 6 weeks, then it will happen.
Excuse me, sir. When we are approaching the radial head through
Focus approach, yeah? I've lost you, Satish.
through Cocker interval.
Yes, it is called the Cockers approach.
Sir, yeah. So, do we need to explore the posterior interosseous nerve or not in this Cocker interval?
Okay, so I'll tell you something. Okay, so you're very lucky you're not in this country. You're in Pakistan. In Pakistan, you can do the Cockers approach. In my part of the world, it is actually considered an offense that you do a Cockers approach. You have to do a posterior approach to the elbow, and then after you cut the skin, then you can do the Cockers approach on the muscle. But you can't just go do a lateral incision on the Cocker approach just to do the radial head. Do you understand what I'm saying? That you do a posterior incision, but a Cockers approach.
Right, got it.
Why so, sir?
Because what is called traum tracking. Do you know what traum tracking is?
I have heard about it, but I don't. I'm not
Explore the nerve first, and then later on do whatever you want to do.
Is what, sorry?
Just to explore the posterior interosseous nerve first, either it's intact or not, to assure that, and later on fix the neck.
I've never looked for one. You know, the more you look for it, the more you get into trouble. No book will tell you to go and look for the nerve anyway, like I said. What do you need to do with your elbow to take the nerve away?
Pronate.
Yes. So if you're doing that and the nerve is falling away from you, why do you want to look for it?
Yes, you don't have to search.
Okay, so come back to this posterior incision and Cocker's approach. You cut the skin, but you approach Cocker where it should be. The reason for that is traum tracking. So in the future, if the person needs a second operation, you've already made a scar, and you make another scar next to it, it makes like a traum track. So the blood supply of the skin depends on the area from where the blood supply is coming in. It should be at least twice the amount of the skin between the distance between the two scars. Does anybody understand that? The trauma tracking is because of the lack of blood supply, the skin dies. The skin to survive has to have twice the distance of blood supply compared to the one between the scars. So if you have two scars, which is 5 centimeters between each other, but the long scar, so that means you need to have 2.5 times or 2 times the distance from where the two scars are to tell you that the skin is going to be alive. Unfortunately, I can't make anything out for you, otherwise I would have shown you.
Okay.
Understand that? No, understand that, no?
Just my question is that when you are going to fix a radial head through a lateral approach, so when you are going to remove,
I don't do a lateral approach. I would do a posterior skin incision, but a lateral approach with Cockers.
We are talking about the why it's offense in UK. You are saying it because of tram tracking issue, right?
Yes.
So why you give 2 incisions on the lateral side?
I don't do incision. I will always go through a posterior incision and take the radial head out from the Cockers approach if I have to, or fix it. Because in the future, when I come back again in say 5 years, 10 years time, when the person needs an elbow replacement or needs another operation, then I would have had made a scar in the Cockers area, which would not allow me to have a posterior approach because I won't be able to.
Right. Though this is about the late arthroplasty or reconstruction procedure.
Yes. So in my practice, मेरे मरीज मेरे साथ कब्रिस्तान जाते हैं. When I operate on them, they don't go away. So I have a system. They all keep coming to me. They have got a problem. They come back to me like everybody else in England or in America in the first world. Everybody you operate on, they don't go away. They will keep coming back to you again. So you are very lucky in Pakistan that you don't see your problems. Whatever I do, they will come back to me. So if I do somebody and I do a bad operation, I will live with it for the rest of my life. Yeah.
Yes.
Okay.
Have you had enough? Are you guys getting bored?
Not at all.
No, sir. Not bored, sir.
Are you sure? Okay.
So fairly camp.
Now, what is this? I'm trying to show you this picture. What is called a primary insult, or when you have an accident, what has happened to you? So this is a gentleman who came to A&E. He has got his
helmet.
Sorry.
When this proximal fracture.
Yes. No, I'm not talking about fractures. Not talking about fractures anymore now. Okay. This is a person who come into A&E, gets an open fracture, and he also has an accident from which the lung is now having problems. So when will you plan to operate on this patient?
2 weeks.
Why 2 weeks? Why not 2.5 weeks, or why not 1.5 weeks?
For second hit, sir.
Just give me 2 seconds. I'll be back in 2 seconds. Okay. Just give me 2 seconds.
Okay.
Sorry. Home social duties, yeah? So when will you plan to operate on the person who comes in with acute respiratory distress problems, has a trauma, has got various other problems? When will you plan to operate on these patients?
Once he is stable enough to tolerate this major surgery.
Right. So how will you know the patient is stable?
By
Come on, guys. You need to tell me a lot more than that.
So when he's maintaining his oxygen saturation up to 95.
Do you know, when you remember you read your physiology books? Do you remember your physiology books when you were reading?
Yes.
Do you remember the Sir Cuthbertson model? What was that?
Which model, sir?
Sir Cuthbertson model, the ebb and flow phase. Do you remember that?
Ebb and flow phase, yes. Yes.
Yeah, ebb and flow phase, yeah.
What is that?
This is about the inflammatory phase of post-traumatic.
It is response to trauma. Human beings respond to trauma, isn't it? In the old days, it used to be called the flight, fight, and fright mechanism. where you have to run away from the problem, and you have to have enough glucose to take you away from wherever you're going. And you have gluconeogenesis, where the glucose, everything is converted into glucose. Do you remember that in your physiology books?
Yes,
Yes.
sir.
Okay,
Bit
so
of it.
now tell me, when will you operate on these patients?
After 3 days,
Don't
and
make
flow phase.
numbers. Go back, sir. I've given you such a big hint. I've told you the ebb and flow
LFTs
phase.
are well, when LFTs are normalized, sir, due
Wait,
to
what are normalized? Sorry,
liver
LFTs.
function test.
what has that got to do with it?
No
Sir,
relation with the
for gluconeogenesis and all.
Operate.
Acute phase reactions.
Operate on these patients before the flow phase or after, when the protein, is getting back to positive balance. So when the protein is being converted to make glucose, if you operate on those person, you have what you call is a second hit theory. Do you understand what that is?
Yes, sir. Second
What is
hit.
that?
Sir, when
The
you
patient
okay, go on.
So the patient is initially trauma, and you are giving him a second physiological trauma by doing surgery in that phase.
Okay, so what happens then?
Sir, in the inflammatory response further goes into a vicious cycle type something.
Okay, so see, I'm giving you concepts now. So it may not be something that is asked of you, but you need to understand what is damage control. Do you know what damage control is?
Yes, you need to in damage control surgery. You address only potential life-threatening injuries by fixing them early.
Yeah, so where did damage control come from?
That is from
Sir,
basically from
Ship.
It's
Ship
a
breaking.
utility ship. They have to make the ship functioning till it comes to port and they can sort it out. So remember that you need to know the Sir-Cuthbertson model. You need to know the ebb and flow phase. You cannot operate on anybody in the ebb phase. You have to operate them on the flow phase. So you need to operate them before they go into negative nitrogen balance or after the nitrogen balance has been corrected. The only way to know that is the hydroxyproline level in the urine. So if I ask you, when are you going to operate on this patient, you will tell me that you will operate on this patient before hydroxyproline comes into urine or after hydroxyproline has been cleared. That is what you have to tell me, not 2 weeks, 10 days, 5 days, 7 days, 11 days. Yeah, this is all science. Agreed?
Yes, sir.
Yes, sir.
Okay, so what you will do is you will do damage control in the meantime until the patient is fit enough to have an operation. Damage controls means you do what needs to be done, minimize everything, do ATLS protocol, do A, B, and C's before you go to D. I'm trying to see if I can fit my writing pad on so that I can show you some diagrams, but I don't think so. I'm succeeding anyway. Okay, good. So remember, okay, damage control, ebb phase and flow phase, operate when the patient is safe. You have to operate when there is no protein, negative nitrogen balance. Agreed?
Okay.
Okay, sir.
Okay, that's a concept that you need to understand. It is a new concept, but unfortunately, this you need to know.
Yes. Hydroxyproline.
Hydroxyproline.
Yeah.
No hydroxyproline in the urine.
Is what, sorry, in the urine? Yes, that will tell you
Yes.
what it says. So what test are we looking at?
This is Simon's test. Simon's squeeze test for the tendo-Achilles function.
What are we looking at? It is telling us what the tendon Achilles is doing, isn't it? Yeah?
Yes, sir.
Okay, so tell me the management of Achilles tendon rupture.
So it depends upon the size of the gap between the two.
No, it doesn't depend on
segments.
Acute and chronic, sir, and
very good.
the
Acute and chronic.
duration.
Okay, so if you have an acute injury and you have never worked on this and you've come to the hospital, the management is different. If you have an acute injury and you have worked on it, the management is different. And if you have a chronic injury, which means more than 4 to 6 weeks of injury, then the management is different. Do we agree with that?
Yes, sir.
Yes, sir.
Okay, so you need to talk like this in the exam, guys. You know, I mean, I'm telling you I'm spending so much time with you guys. You need to reward me by talking the way I talk, you know?
Okay, sir.
You must. The only way it's not about exam. The exam is not when you pass your exam. The exam is when you go to a patient and he asks you a question. Okay, so tell me the management of this patient now. So this patient came in, he was playing football and he felt a snap. He's 45 years old and he came straight to the hospital. What are you going to do with this patient?
Sir, after history and examination,
Yeah?
sir, I will do this squeeze test.
So you've done a squeeze
and,
test, positive.
X-ray, sir, for any.
You don't need an X-ray.
Factor.
You will need to do an ultrasound. Okay.
Okay.
Either you do the squeeze test or you do the ultrasound. So that has told you that the person has got a problem. What are you going to do next then?
So the operative treatment is always better than non-operative treatment because it is noted
now you've
that
got yourself into trouble. You said that to me the exam, and if I was your examiner, you'll have to come back again. Okay. So there is no difference long term between operative and non-operative in patients who are acute injuries who have not walked on their feet. Okay, and the reason is how the ankle behaves. I'm sorry, I'm not distracted. I'm just trying to see if I can get. I'll do it next time. Yeah. Okay. So if you see them, the complications for Achilles tendon after surgery are higher than when you operate them. However, the re-rupture rate is higher if you do them non-operatively. Is that clear?
Yes, sir.
Yes, sir. Yes.
You have to offer the choice to the patient. In here we do. We give them the pros and cons and we tell them whether he wants it operative or non-operative managed for this. The only choice given to these are the patients who are acute injuries who have not weight beared on their legs, i.e. they've hurt themselves and they're brought straight to hospital, so they have not put any weights on it. And the reason for that is if they put weight on it, then the tendon Achilles margin separates. Okay, and when it separates, it becomes difficult to repair them non-operatively. You have to then do something with them surgically. So the management for an acute injury who is not weight beared on his ankle is either operative or non-operative, the choice the patient makes. And the choice, you tell them that when you operate, there will be higher complication rates such as nerve problems and scar healings and issues like that. But if you don't operate on them, they will have no issues with complications like that, but they will have a higher re-rupture rate. The higher re-rupture rate is only 5% more. So you offer both choices to the patient and then let the patient decide. Okay?
Okay, sir.
For a person who has actually walked on his heel or has come to you more than 4 weeks later, there is no other choice but to operate on those.
Okay.
Okay.
That's because the ends will not come together. What if you see somebody with a huge gap and has come to see you about 12 weeks down the line? How are you going to manage that?
Need to reconstruct his tendon Achilles.
There's other things you can do.
By taking allograft, by taking grafts.
You can do gastric nemus, one. Okay.
Yes, sir.
You can do plasty of the gastric nemus muscle at higher up in the tendon. Okay, proximally.
Yeah.
You can do that, or you can use a plantaris graft if you want to do that, or you can use an allograft. What allograft is commonly used around this?
Sir, I could not hear. Please kindly repeat it, please, sir.
Okay. So if you want to if you have a patient who has got an Achilles tendon chronic rupture and there is a gap of more than 5 centimeters between the Achilles tendon margins, yes?
Okay.
So you have to bring it down. So the only way to bring it down is you can do it proximal or distal. So if you want to do it proximal, you do what is called a VY-plasty, where you release the gastric nemus in such a way that the tendons can be brought down. And sometimes even those you have to augment with a plantaris graft. The plantaris is nearly always left, even though the gastric nemus is torn. The tendon Achilles is torn. The plantaris is always available to use as a graft. Okay. Your first choice is to do that if you want to. Your second option is to do an allograft, and your third option is to do a prosthetic graft. So if you want to do an allograft, which means you take the graft from somebody else who is obviously dead, then you can do what is called a Achilles tendon graft, where you can get a piece of bone with the Achilles tendon. Or you can do what is called a artificial graft or a synthetic graft, and that graft is called a Lars ligament. Okay, so you fill the Lars ligament. Yeah, it is a system where this is just an artificial synthetic graft. You screw it into the calcaneum, and then you take it to the top and you weave it through the tendon, and then you put the tendon across it so you fill the gap in line. Okay, so again, proximal, distal. Proximal, do VY-plasty. Distally, you can do a plantaris. You can do an artificial graft, or you can do an allograft. Okay. Go on then. This is especially for you, Satish. What is this?
Yes,
Now? This is a gentleman who is 89 years old and he's come with something like that. He's had a fall from his bed.
Yes, this is the X-ray knee, epi and lateral view skeletally mature patient showing a periprosthetic fracture of the distal femur, and I can appreciate a well-fixed total knee implant and the epi and lateral views.
Is there a classification you know which tells you about periprosthetic fractures with different type of implants?
Yes, sir. There is a Lewis and a Rorabeck classification for periprosthetic fractures around the knee joint.
Okay, educate me. Go on then, Satish.
Okay, there are three types in Rorabeck classification. Number one is undisplaced fracture with a stable implant. Number two is displaced fracture with a stable implant. And number three is a displaced fracture with unstable implant.
Okay, so why do you not use the Vancouver classification?
So Vancouver is used for a periprosthetic fracture of femur with a hip arthroplasty.
Very good. See, everybody was saying Vancouver behind you. Vancouver was specifically designed for proximal femur fractures. Okay, everything else is what you've just described. Like, okay, so in this classification that you've just described, which type is this?
This is type 2, sir.
Very good.
Because
so how are you going to manage this?
After history examination and lab investigations, I would like to fix that. I can fix that with either a plate and I can.
You've just now said something that you should do the exam. You will say that, assuming that this is an isolated injury, patient is fit to have an operation. You know, we use a word in England which is called not fit to have a haircut. What does that mean? You cannot fix people who are not medically fit to have an anesthetic, isn't it? So you have to say this that this patient has got a periprosthetic fracture, assuming that this is an isolated injury, the patient is stable, can have an operation. I will consent him for managing this patient doing what? What would you like to do?
Sir, I would like to do open reduction and interfixation with the distal femur locking plate.
Okay. Again, you're right. That's what I would do. But there are, in the exam, you will say there is operative and non-operative management. Okay. In a non-operative management, I am not used to it, but a skeletal traction and a fixed traction will help. In an operative methods, I have two types. I can either do an intramedullary or an extramedullary fixation. The intramedullary fixation is all knees have got a place in the middle. If you've ever seen a knee replacement, they have a plastic in the middle. Have you seen it?
Yes, sir, we have seen.
Why is that?
So for retrograde kneeling?
In the middle. Why do you think it is? It's to take the
retrograde kneeling.
So you can put a nail through it. Okay?
Yeah.
So all knee replacements that you have, next time you have a knee replacement, have a look at it. The implant will have a plastic in the middle of it or space enough for a nail to go through it. So you can put a nail through it or you can plate it. Now, if you're going to plate it, which side are you going to put that plate on?
Lateral side, sir.
Why?
Because lateral side is the tension side in the femur.
Not necessarily always, but yes, that is generally what it falls. You look at the X-ray, and if you look at the X-ray, the lateral side is the tension side, and that's why you put a plate on it. What would you call this plate then?
We can call it as a tension band.
Yes, it is the AO principle of classification. If you look at the AOA, if you're putting a plate and using on the tension side, then it becomes a tension plate, or the lateral plate is now a tension plate, isn't it? Okay, so you must understand that there is not one way to skin a cat. But in the exam, you must show your knowledge to the examiner. You can say that this can be managed operatively or non-operatively. This is a standard answer for every operation. You must make sure the patient to have an operation. You must make sure that you have discussed various possibilities of the options. You must make sure that your choices are, if you're fixing it, intramedullary and extramedullary. Okay? So if you say it this way every time, you can't miss anything out. Is that agreed?
Okay, agreed, sir. Agreed.
So we know what classification this for everybody else. Can you repeat? Maqsood, can you tell me what classification did Satish?
Lewis.
What, sorry?
Wasn't it Lewis classification, sir?
Oh, Satish, I don't think so. You said Lewis, did you?
Yes, sir. There is Lewis and Rorabeck classification.
Okay, so I remember the Rorabeck classification, but you can call it the Lewis and the Rorabeck classification. Okay. So you must remember, for a distal femur is a different classification, and proximal femur is a different classification. Okay, good. Well done. So you must remember, you can only manage these patient if he's fit to have an operation. We have a saying in my practice, and he's not fit to have a haircut, which means that he's not fit to have an operation. It's true. If you can't be having a haircut, how can you have an operation? Isn't it like, yeah? Hey, I don't think so. We've gone through all of these. Yeah, let's do this. This is the last one, and then we call it today. I think we've had enough. I think I'm boring you now. Like, yeah.
Not at all, sir.
No, sir. We are actually enjoying.
I want all of you, now that you've come to this stage, you must pass the exam. Once you've crossed the MCQ, which is the difficult bit, the clinical bit is the easy part of the exam. It is the easiest part of the exam because you can defend yourself. Do you understand what I mean by that? You can defend yourself. You can say things that the examiner can, listen to you. Where in MCQ, you have no choice. Whatever you've written, if it doesn't match the key, you cannot come back. So all of you must pass this exam. Once you've come this far. All right, okay. So one final one, and we'll call it a day. Who wants to go? Everybody's gone quiet, yeah?
No, sir. This is.
You're going to pass the exam. You're taking too much glory and too much limelight, isn't it? Let others have a go.
Yes. Anybody can participate. Dr. Mohsen, you can participate.
Okay, sir. Okay,
yeah, you're very quiet, isn't it? I can see you sitting there. Do you want to participate? Yeah.
I have some hearing problem. That's why.
You have a hearing problem.
A hearing problem during this Zoom, sir.
Okay, so go on then.
Okay, this is an X-ray.
You can watch it then if you want to.
This is an X-ray of skeletally mature patient AP, lateral view of the.
That's a lateral view, yes.
Yes, a lateral view of the showing distal tibia fibula ankle joint and the.
You don't have to say that in the exam. You say that this is the lateral view of the ankle of the leg, which is showing fracture of the calcaneum.
Okay.
You don't have to say that this is, because if you say that you're worse than an anatomy student, you should know what this is. So in the exam, come directly to the point if you know and you're happy with this, okay? So this is an X-ray which showing fracture of the calcaneum. All right?
Fracture of the calcaneum, yes, sir.
So what lines do you need to know if you're talking about calcaneum?
Two angles. One is the Bowler's angle and the Ghisani's angle.
Very good. Do you know where these guys were from?
Yes, sir. Posterior facet.
Sorry?
No idea, sir, from where they are.
Working in the Birmingham Accident Hospital.
When I
was doing my registrar rotation, where the education center was, on the door they had both these pictures, and for the first 3 months I had no idea who they were, and I kept on asking and nobody told me until I met the oldest professor in the hospital, which was Professor Pluis. He told me these are pictures of Ghassan, who used to work here, and he was in the Birmingham Accident Hospital, which is now the QE Hospital. So they are Birmingham boys. Okay? The Polomin theory came from Birmingham. Nigel Tubbs, he was my boss. I worked with him, and he used to call it the Polomin theory. Like, he was a big arthroscopy surgeon. He was a surgeon who started his career by doing from the lithotomy position from knee arthroscopy from the medial side. So he was that old, but he was an amazing chap. Anyway, so coming back here, there is Ghassan and Bowler's angles you need to know. What are those angles?
So the Ghasani's angle is basically an obtuse angle.
Okay. You can see you've got one bit there, and you have. So if I was to ask you that what is happening to the Ghassan and the Bowler's angle in this X-ray?
So the Ghasani angle is basically reducing, and Bowler's angle is increasing.
It's nearly flat, isn't it? So what is the reason why we need to know these angles?
So basically to classify the fracture, as there is axial load, so there is a depression of the calcaneum by the talar.
Tell us whether we need to fix this or not. Okay. The classification is a CT scan based classification, and that's dependent on how you fall on your calcaneum. That's okay. It's a good classification, but for somebody who is doing trauma day in and day out, he needs to know whether he wants to fix them or not. So you need to look at the Ghassan angle, you need to do the Bowler's angle, and there's one more thing you need to do before you decide whether you want to fix it or not. Look at the Harris view. What are you looking at on the Harris view?
Widening of the.
Yes, you want to see whether the calcaneum has gone into varus or valgus, and can you wear a shoe? Okay, so these three things you do will tell you whether you need to fix it or not. So if you look at it, you know that this needs fixing because both the angles are gone, and in the Harris view, the whole thing is shortened and broadened, so you can't wear a shoe, and the angles are all gone. So if you not fix them, they will be having problems weight bearing in the future. So the next thing I'd like to do is actually have a CT scan, isn't it? So there's your CT scan. What does that tell you?
Sir, it's a three-part fracture.
I don't know of any classification which says 3 parts.
Sanders classification.
Sorry?
Sanders classification.
Yeah, I know. But in the exam, what you're going to say is that the calcaneocuboid joints, the sustentaculum tela is all intact, although the body of the calcaneum is fractured, is it? You need to describe what you see rather than put classification onto it.
Okay, sir.
So what joint is this? Calcaneocuboid is okay, isn't it? It's maintaining itself.
Okay.
Although there is a big nasty fracture, the most important joint is intact. It's working, right? And the sustentaculum tela is also intact. Can you see that? It's one big piece. Okay?
Right, sir.
And if you look at this particular picture, although this is a nasty fracture, would you think you can leave this as non-operative management? You can see an articular surface.
It is not displaced, sir.
It is not, but you can see the articular surface here. Can you see this line?
Yes, sir.
That's come from somewhere else, isn't it? So you can see there's foreshortened, and the articular surface somewhere is not where it should be. Although most of it is okay, which means you need to be relatively little fixation, but it does need fixation. If you were going to fix this, how would you fix this?
Sir, with the buttress plate, sir.
No. Before you go to the buttress plate, you need to tell me basics. So what type of fixation? This is a different type of fixation. This is a fixation that happens nowhere else in the body. There is a name specifically for calcaneum fracture fixation.
So initially, we'll go for a preliminary fixation, and we'll make so there's a particular name for it.
You can do a non-operative management of putting this patient in plaster and manipulating it. Okay, you can do an operative management by either plating it or putting an external fixator on it. There are 3 or 4 pin external fixators specifically for calcaneum fractures. But if you were going to plate this, what approach will you use and how will you get to it?
Posterior lateral approach.
Very good. So you need to make sure that you make a big, huge, fat, thin flap. The whole thing comes together, otherwise the skin will die. Yes? And if you tell me the name, you get 100% for today. I will think that I've done it well today. What's the name for this particular approach that you use for calcaneum fractures?
Reverse JSA.
Is what?
So lateral extensile approach.
Is what, sorry?
Lateral extensile approach, or there's a particular name for it?
But it is called a transosseous fixation. You are fixing the other side through the lateral side. Do you understand what I'm saying?
Yes.
You are fixing this side, but you're approaching it from this side.
Exactly.
It is called a transosseous fixation. Not many fractures you see in the body that has this particular type of management. Okay? So in the exam, you will say that I would like to know the Ghassan view, and I would like to know the I forgot it's the Ghassan view, and there was the Bowler's angle. Sorry, and then I look at the Harris. Depending on these 3 views, I'll decide whether I need to fix it or not. Classification, if somebody asks you, the easiest thing is that classification of calcaneum depends on, it's a CT scan based classification. It depends on how your talus is when you fall, whether the talus is in rotation, eversion, inversion, wherever. And if you don't remember it, tell it the exam, this is the good, the bad, or the ugly classification. All right? And if somebody says anything to you, Dr. Shah said this is what it was like, isn't it? So they will not challenge you after that one. The good, the bad, the ugly. But if you remember the classification, it's even better. Okay? So this is a extensile natural approach. The careful thing is that you have to take big flaps out with skin, fat, and everything together, and you do a transosseous approach.
Transosseous fixation.
Yeah, it's true, isn't it? You're putting a plate here, but you're getting all that sorted out, isn't it? You knew this before I told you, isn't it? Did you know about the transverse physics approach? Nobody did. Okay. So this was what I was going to show you about the mess, but I didn't have. You didn't have the extra time. I think we went through this. Everybody told me this earlier. You missed it, Satish. So
Yeah, sir.
dislocated elbow, dislocated knee.
I'll review the recording, sir.
Yes, yeah. That's why nobody wants to join us. You know that they all wait for the recording and then see the recording. They don't have time to come and talk to us. What's this? Patellar fracture, yeah. So why is patellar fracture?
Patellar fracture. Yeah.
So what this method of fixation is called tension band fixation.
Tension band.
Tension
What does
band
that mean?
wiring.
What is tension band?
Sir, it is the process converting the tensile forces into compressive forces.
Yeah. So does it work everywhere? So what are the places you know of tension band fixation? What places do you know?
So greater tuberosity has been discussed.
Sorry?
Greater tuberosity.
Yes. Patella is another one. And there's one more.
Olecranon.
Fractures. Yes. Okay. So if I use a pins, yeah, and a wire across it on a fibula, is that tension banding?
Sir, it should have compression, sir.
There is none. So what is it called then? It's called a figure of 8 fixation. Okay. So you're all very lucky that you don't come for exams to me. I am a very purist. I'm a very purist. If you tell me there's a tension band and it's a fibula fracture, then unfortunately we have a nice talk then. Okay. I think we've all had enough. You know, I'm getting tired too. So what time do you want to start tomorrow?
At 7 p.m., sir.
Okay, that's good. That could work. Tomorrow there may be a chance that Arif Saab wants to teach you spines. If he doesn't have time, he is the BOA president. He has got not much time. But if he's available, then we'll let him have his first go. Okay, so he can teach. But I'm available all day tomorrow. I'm free. I've got nothing to do. So we'll if I don't see you now, we'll see you at 7 o'clock. Okay, on Sunday.
Pakistan time, sir.
Pakistan time 7 o'clock.
Okay.
PM, yeah. So on Sunday, my colleague, Mr. Moore, is going to talk about prosthetic joint infections. Yes, and Shahid Nur Saab is going to talk on arthroplasty and what you need to know on arthroplasty for exams.
Right.
So that's Sunday.
Excuse me, sir. I have one question from today's talk.
Okay.
Sir, regarding fractures of humeral shaft, when we have suppose done the ORF of humeral shaft, and in the post-op period we have found radial palsy.
Yeah.
So what we should do now? Either to explore or wait and watch.
No, explore. Because
Sir, most of the time,
you've done something to it, yeah.
Yeah.
Sir, most of the times it's a neuropraxic injury. During operation, you have a traction of the nerve. So it could be a neuropraxia or something like that. So why we are exploring again? Can't we wait for
a surgeon to get neuropraxia while plating the humerus? 9 out of 10 times it is the nerve on top of the plate on top of the nerve. You have neuropraxia during injuries. So if you have a nerve problem before you had a fracture fixation done, then you can leave those alone. We just discussed that. You can leave them for 6 weeks. When the EMG, the nerve conduction studies will tell you whether the nerve's working or not. You can't leave it longer than 6 weeks because it becomes irreparable then. If it starts axon degeneration, then you can't repair them. You can't salvage them. However, if you have injury after surgery, the protocol is very simple and straightforward. You have to go and look for it because your plate is catching it.
Oh, okay. Thank you, sir. Thank you very much.
Sir, I have a question, sir. Excuse me, sir.
Okay.
Sir, regarding tendo-Achilles rupture, one question is in acute cases, can we do direct repair of that tendo-Achilles, sir?
Yes, that's what we do. In acute cases, we always do a direct repair. So there's a paratenon and there's a nerve next to it. You have to find the nerve, you open and split the paratenon, and then you repair it. So any tendon you repair in the body has got the same principle, whether it's the finger, the tendon, the supraspinatus. Can you tell me what that principle is? Repairing a tendon, how do you repair a tendon?
Kesley repair.
So you have a core suture and a running suture. The core suture is where the strength is, which brings it together, and a running suture smoothen it so it can glide. Okay? Now, you always have two parts of the repair. There's a core suture and there's a running suture. When you're doing tendons in the finger, the same principle. If you're doing Achilles tendon, the same principle. If you're doing supraspinatus, we do the same principle. It is a two-layer process. The first layer is the core suture for the supraspinatus, and the other suture is putting the end smoother to make it glide, like we said. Remember that all tendons work the same way.
Okay. And sir, what about the repair with the flexor hallucis longus in case of tendoachilles, sir?
You can use that as a spare body. You can use it.
Okay.
Only if it's a chronic repair. You don't need to use it in acute repair. Most acute repairs come very nicely. You don't have to use it if you don't want to.
Sir, I have a problem. I am not getting understand that in acute repair, can we also do with the augmentation with the plantaris and all that?
Okay.
And in chronic cases, what we do? We do flexor hallucis longus or gastrocnemius recession and advancement. Kindly elaborate this.
So I'm going to say this again. I want you all to be clear. Okay. So the first thing is you have an acute injury and you have a chronic injury. Okay. So if you have an acute injury and the person has not worked on it, then you can manage this operative or non-operative. Okay, depending on what the patient wants. In these scenarios, if you're doing an operative management, you don't have to augment it. Okay, they will heal because they will heal in a plaster. So I'm sure they will heal when you bring them together and stitch them. So now it comes into people who have acute injury, who have walked on their heels, or people who have chronic injuries. So people who have acute injuries, who have walked on it, when you repair them, you have to augment them. Okay. So you can use whatever you want to use it, but you have to augment the ones that have been walking after they've had an acute injury. The chronic injuries are totally different thing altogether. The chronic injuries, you have to decide, depending on your experience and your past results, you can use proximal or distal. So you cannot do more than 5 centimeters. You can do it proximally. Okay? You cannot do more than that. But then you have to go into the realm of having either an allograft or an artificial graft, such as a Stedelijk or a last ligament. Okay, so make sure that now it is all clear. Okay, you can't confuse this. Acute injury who have not worked on it, you don't have to repair them. But if you do, you don't have to augment them. Acute injuries who have worked on them, you have to repair them. There is no choice. You can't put them in a plaster. You have to repair them and you have to augment them. Okay? Chronic injuries, you have to decide how far the gap is, and if it's a small gap, you can do VY. If it's not a small gap, then you have to do an allograft or a synthetic graft, a last ligament. Are we clear on that?
Okay, sir. Thank you so much.
I'll see you tomorrow at Pakistan 7 time. I will let you know if Arif Saab wants to teach before that. Okay, but I'll let you know.
Okay.
Okay, sir. Thank you very much.
So much, sir.
Thank you, sir.
All right, forget. The video is going to be recorded, and when it's updated, I will upload it for you guys. Right?
Okay. Thank you, sir. Thank you very much.
So much, sir.
Thank you.